Good morning, everybody. The topic for today's presentation is supranuclear control of ocular motility. Introduction. Eye movements are the most precise and highly coordinated motor functions. Control of eye movement occurs at three hierarchical levels: supranuclear, nuclear, infranuclear. The supranuclear ocular motor system occupies the highest level of this hierarchy and is responsible for the planning, initiation, coordination, and control of voluntary and reflex eye movement. The three-tier hierarchy of gaze control. Cortex decides when and where the eye moves. Brainstem decides how they move. Voluntary eye movements are generated in brainstem but triggered by cerebral cortex. The supranuclear network is the assembly of pathways above the ocular motor nuclei. All commands converge on the final common pathway, cranial nerve 3, 4, 6, and their muscles. These structures include cortical gaze centers, such as frontal eye fields, supplementary eye fields, parietal eye fields. Subcortical structures like basal ganglia, superior colliculus, cerebellar pathways. Brainstem gaze centers, such as paramedian pontine reticular formation, rostral interstitial nucleus of medial longitudinal fasciculus, interstitial nucleus of Cahal, and vestibular nuclei. These are the functions of supranuclear control of gaze. First, saccades. 2. Smooth pursuits. 3. Vestibulo-ocular reflex. 4. Optokinetic nystagmus. 5. Vergence. 6. Visual fixation. So, the six eye movements are saccades, the purpose of which are rapid foveating movements to the new target. It can reach peak velocity up to 800 degrees per second. It is generated by PPRF and RIMLF. Smooth pursuit. The purpose is tracking slowly moving targets. It can reach peak velocity up to 70 degrees per second. It is generated by paretotemporo-occipital junction and flocculus of the cerebellum. Third one, vergence. The purpose is binocular focus on the near target. The peak velocity is less than 25 degrees per second. It is generated by mesencephalic reticular formation. Fixation is the purpose of fixation is holding the gaze on a stationary target, that is, it doesn't move, that is 0 degrees of movement per second. This is generated by superior colliculus and frontal eye field fixation cells. Vestibulo-ocular reflex. The purpose is to stabilize the gaze during head turning. The peak velocity matches with the movement of the head. It is generated by semicircular canal and vestibular nucleus. Optokinetic movements. The purpose is stabilizing during sustained motion. The velocity is variable. It is generated by vestibular system. Here is the list of ipsilateral muscle. It is its yoked contralateral muscle and the combined plane of action. Medial rectus and lateral rectus, the plane of action is horizontal. Superior rectus, inferior oblique, the plane of action is elevation. Inferior rectus, superior oblique, plane of action is depression. Superior oblique and inferior rectus, the plane of action is intorsion with depression. Inferior oblique and superior rectus, the plane of action is extorsion and elevation. We should also remember the two important laws. 1. Herring's law of dual innervation. The yoked muscles of the two eyes receive equal and simultaneous innervation. Sherrington's law of reciprocal inhibition. Antagonist muscles are inhibited when agonists contract. Together, they ensure conjugate precise eye movements. The failure of this either law, as it occurs in internuclear ophthalmoplegia, generates cardinal nuclear supranuclear signs. So, how to differentiate supranuclear versus nuclear or infranuclear pathology? When it comes to eye movements, saccades are disproportionately affected and are often very slow in case of supranuclear, whereas in nuclear, they are equally affected with other movements. Smooth pursuits are mildly affected in supranuclear regions. where it is equally affected as other movements in nuclear and infranuclear lesions. Vestibulo-ocular reflex is spared in supranuclear lesions, but it is equally affected in nuclear infranuclear lesion. Optokinetic nystagmus, quick phases, there will be saccadic palsy in supranuclear lesion, whereas in nuclear infranuclear lesions, the optokinetic nystagmus quick phase is lost. Diplopia is often absent in supranuclear palsies, whereas in nuclear infranuclear it is usually present. Pupils are spared in supranuclear, whereas may be affected if there is third nerve involvement in nuclear or infranuclear lesions. Coming to cortical gaze centers. Frontal eye fields. Located in the lateral precentral sulcus or the posterior part of middle frontal gyrus, localizing to Brodmann area 6. The function is voluntary saccadic eye movement, initiating the rapid gaze shift towards the object of interest. Triggers an intentional retinotopic saccade, that is, visually guided, predictive, and memory guided saccades. Influences the brainstem gaze centers via descending projections to contralateral PPRF and ipsilateral superior colliculus. The clinical significance is a destructive lesion will produce transient deviation of the eyes towards the side of lesion and impaired voluntary gaze to the opposite side, whereas an irritative lesion may cause forced conjugate eye deviation away from the affected hemisphere. Parietal eye fields, posterior parietal cortex. The location is primarily Brodmann areas 7 and 39 in the posterior parietal cortex. The function is responsible for visually guided eye movements, direct attention towards the novel visual stimuli, important for reflexive saccades towards suddenly appearing targets. It integrates visual, auditory, somatosensory information. It assists in spatial orientation and visual exploration. The clinical significance is the lesion will produce visual neglect and impaired visual scanning. Patient may ignore objects in the contralateral visual field. Supplementary eye field. The location is medial frontal cortex anterior to the primary motor cortex. The function is planning and sequencing of the eye movement, coordinating the complex saccadic tasks involving in memory guided saccades. The clinical significance is lesions impair the performance of complex eye movement tasks while simple reflexive saccades may remain intact. Dorsolateral prefrontal cortex. The function is executive control of the eye movement, suppresses unwanted reflex saccades, critical for anti-saccade tasks looking away from the stimulus, participates in the work memory related eye movement. Clinical significance is lesion results in inability to suppress reflexive gaze shifts. Occipital cortex. The function is providing visual input required for pursuit movements. Processes motion perception, sends information to parietal and temporal visual association areas. Clinical significance is lesions impairing visually guided tracking. Temporal cortex, middle temporal and medial superior temporal areas. The function is to analyze the visual motion as it is essential for smooth pursuit eye movement, detects direction and velocity of moving targets. The clinical significance is lesion causes pursuit deficits and inability to accurately follow the moving objects. 4 cortical saccade control areas: the area, location, and the primary role. Frontal eye field, precentral sulcus or midfrontal gyrus, Brodmann's area 6. The primary role is intentional saccades and disengaging the fixation. Parietal eye fields, intraparietal sulcus and angular gyrus, Brodmann area 39 and 40. Primary role is reflexive visually guided saccades. Supplementary eye fields, posteromedial superior frontal gyrus, the role is sequencing and complex motor programs. Dorsolateral prefrontal cortex, Brodmann area 6, the role is memory guided saccades and anti-saccade inhibition. Oculomotor apraxia, It's a disorder of voluntary eye movement initiation characterized by difficulty in generating purposeful saccades, despite having a normal ocular motility and intact extraocular muscles. Patients are unable to rapidly shift their gaze to a new target on command. We should observe for head thrust phenomena. Here, patient often compensate for the initiation defect by making sudden thrust of head beyond the object of interest, after which the eyes catch up to the target. This characteristic finding is a key clinical feature of this condition. Preserved reflexes. Reflex eye movements like vestibulo-ocular reflexes are typically preserved in oculomotor apraxia. Etiology and forms. It can be congenital oculomotor apraxia. It is often referred to as Cogan's congenital oculomotor apraxia. Typically presents in infancy with a difficulty in initiating the horizontal saccades. Acquired oculomotor apraxia, it results from lesions involving the cortical and subcortical network responsible for saccadic generation. The damage typically localizes to frontal eye fields, parietal cortex, basal ganglia, superior colliculus, and other structural interconnections. The neurodegenerative and hereditary conditions like ataxia telangiectasia, ataxia with oculomotor apraxia can be associated with oculomotor apraxia. Important descending pathways. The cortical gaze center project onto basal ganglia, superior colliculus, vestibular nuclei, cerebellum, pontine gaze centers, rostral interstitial nucleus, and medial longitudinal fasciculus. These structures ultimately influence the ocular motor nuclei. Cerebellum in ocular motility. The principal coordinator and calibrator. It's a calibrator rather than a primary generator of gaze. Input and modulation. Sensory and motor input from the cerebral cortex, vestibular system, and superior colliculus and the brainstem gaze centers. The gaze optimization. It ensures accuracy, conjugacy, and overall stability of the gaze. Retinal image stabilization. Through its connections with vestibular nuclei, ocular motor brainstem center, it keeps the visual images on the retina during concurrent head and eye movements. Functional anatomy and regional eye signs. Flocculus. The function is responsible for the smooth pursuits, gaze holding, adaptation of vestibulo-ocular reflex, and modulation of gain of vestibulo-ocular reflex. The lesion manifestation is damage to the structure will result in gaze-evoked nystagmus. In this image, we can see gaze-evoked nystagmus. In this image, we can see downbeat nystagmus. In this image, we can see rebound nystagmus. Impaired smooth pursuits. Dorsal vermis and vestigial nuclei. The function is to regulate saccadic amplitude, accuracy, and smooth pursuit. The lesion manifestation is posterior or dorsal vermis lesions will lead to saccadic dysmetria, resulting in overshooting or undershooting. Overshooting dysmetria. Nodulus. The function is to participate closely in vestibular processing, velocity storage mechanism, and maintenance of equilibrium. The lesion manifestation is dysfunction leads to positional nystagmus, periodic alternating nystagmus, and abnormality of ocular alignment. Saccadic intrusions. Clinically, cerebellar disease produces a signature spectrum of supranuclear abnormalities, prominent among which are involuntary saccadic intrusions that disrupt stable fixation. These are pathologically categorized by the presence or absence of pause between the movements. First one, the one with the pause, that is, with intersaccadic interval. Square wave jerks. These are characterized by 0.5 to 3 degree shift with a return to fixation after roughly 200 milliseconds. It is considered pathological if amplitude exceeds more than 1 to 2 degree. The associated conditions are cerebellar disease, progressive supranuclear palsy, multisystem atrophy, Alzheimer's disease, Huntington's disease, and Friedreich's ataxia. Macro square wave jerks are said to be present when the movement amplitude is larger than 20 to 40 degrees. Macrosaccadic oscillations. The manifestation is extreme hypermetria where the eyes sequentially oscillate about a central fixation point. It reflects impaired fastigial nucleus or superior colliculus fixation cells. The second one, the one without the intersaccadic interval, that is ocular flutter. It features rapid horizontal back-to-back saccades lacking any intersaccadic interval. It signals underlying brainstem or cerebellar disease. The second one is opsoclonus, also called saccadomania. These are continuous multidirectional conjugate saccades of larger amplitude that persist even during sleep. The etiology here is it is strongly associated with paraneoplastic syndromes such as neuroblastoma in pediatric patients, small cell cancer and breast cancer in adults. It is as well as it is associated with post-infectious and autoimmune etiologies. The mechanism is disinhibition of the burst neurons due to functional failure of the omnipose neurons. So, coming to the region, the function, and the lesion that it produces. So, dorsal vermis, the function is saccade accuracy amplitude. The lesion will cause saccadic dysmetria, macrosaccadic oscillations. Posterior vermis, the function is to pursuit and saccade accuracy. The lesion produces hypometric saccades and impaired pursuit. The region flocculus, the function is vestibulo-ocular reflex and pursuit movements. The lesion will produce gaze-evoked nystagmus, rebound nystagmus, downbeat nystagmus. Nodulus and uvula, the function is to control velocity. The lesion will produce periodic alternating nystagmus. Coming to saccades. Saccades are rapid conjugate ballistic eye movement that abruptly shift the line of sight from one target to another. Their primary function is to place an object of interest onto the fovea. They are the fastest movements produced by human body, reaching velocities 500 to 700 degrees per second. Once initiated, a saccade cannot be altered, characterizing it as ballistic movement. Types of saccades. Voluntary volitional saccades, the movements made on command such as looking at a clock or shifting gaze between objects. These are controlled by cortical areas including frontal, supplementary and posterior parietal cortex. Reflex saccades, these are automatic movements triggered by sudden appearance of visual or auditory stimulus requiring minimal conscious efforts like turning eye towards the flashing light. Intentional saccades, these include visually guided, predictive and memory guided movements. Anti-saccades, these are directed opposite to a suddenly appearing target which test the function of dorsolateral prefrontal cortex. Vestibular induced saccades, these are produced during vestibular stimulation to help maintain visual fixation during head movement. Neurological control, cortical control, frontal eye fields responsible for initiation of voluntary saccades, parietal eye fields responsible for reflexive saccades, supplementary eye fields responsible for planning and sequencing. Superior colliculus integrates visual, auditory and somatosensory information and converts sensory input into motor commands. Lesion causes impaired reflexive saccades and difficulty in orienting to the new stimulus. Brainstem pathways, omnipose neurons. These are tonically active neurons that inhibit burst neurons. Excitatory burst neurons will activate before a saccade. Pontine paramedian reticular formation (PPRF), it controls horizontal gaze saccades. Rostral interstitial nucleus of MLF (RIMLF) controls the vertical saccades. Abnormality in saccades, slow saccades. These are seen in progressive supranuclear palsy, especially vertical saccades. These are also seen in spinocerebellar ataxias, brainstem lesions, and oculomotor apraxia. Hypometric saccades. These are undershoot target seen in cerebellar disease and Parkinson's disease. Slow saccade movements are shown here. Hypometric saccades. These are overshoot target seen in cerebellar vermis lesions and fastigial nucleus lesions. Square wave jerks. These are small unwanted saccades away from fixation, followed by corrective saccades seen in PSP cerebellar disorders and Parkinsonism syndromes. Obsoclons. These are multidirectional chaotic saccades seen in paraneoplastic syndromes, viral encephalitis, and autoimmune disorders. Brainstem saccade generators. Excitatory burst neurons, horizontal saccades, located in the PPRF rostral to the abducens nucleus. Vertical saccades, located in the rostral interstitial nucleus of MLF in the midbrain. Omnipose neurons, located in the nucleus raphe interpositus. Function: tonically inhibits excitatory burst neurons, except during the saccades. Neural integrators, horizontal saccade, nucleus prepositus hypoglossi, and medial vestibular nucleus. Vertical saccades, interstitial nuclei of Cajal. Clinical examination of saccades. Key factors to assess are latency, speed, accuracy, conjugacy, trajectory. Examination method. Ask the patient to follow a moving target in both horizontal and vertical planes. Then observe for smoothness, symmetry, presence of catch-up saccades. Pursuit system. Smooth pursuit is a specialized slow conjugate eye movement system designed to maintain image of a moving target on the fovea to preserve the visual acuity. Unlike saccades, which are ballistic, smooth pursuit is a feedback controlled process requiring moving visual stimulus. It relies on complex neural network involving cerebral cortex, cerebellum, brainstem, and it's essential for everyday activities like reading, driving, sports. The nature: it's a slow conjugate eye movement that are feedback controlled rather than ballistic. Function: keeps the image of a moving object centered on the fovea. Velocity: typically effective up to 30 to 50 degrees per second with a maximum velocity of approximately 70 degrees per second. Components: sensory, motion detection, motor, command generation, attentional spatial, focusing on the target. Neural pathway, sensory input, starts at the retina, travels through the lateral geniculate nucleus to the primary visual cortex. Processing, visual information moves to area MT for speed and direction and to the area MST for complex motion signal integration. Execution, signals are sent to the frontal eye fields, pontine nuclei, cerebellum and vestibular nuclei before reaching the oculomotor nuclei to generate the movement. Role of the cerebellum. The cerebellum is essential for precision and adaptation of pursuit. Flocculus and paraflocculus helps in matching the eye velocity to the target velocity. Vermis handles the pursuit adaptation and tracking precision. Fastigial nucleus manages calibration and coordination of eye velocity. Clinical considerations, abnormalities. Saccadic pursuit. The eye uses multiple small corrective saccades instead of a smooth motion, seen in cerebellar disorders, Parkinsonian syndromes, PSP, Huntington disease, and aging. Asymmetrical pursuits, often caused by unilateral parietal lesions, cerebral hemisphere lesions, or brainstem disorders. Difference between saccades and smooth pursuit. The speed is very fast in saccades. Function is to shift the gaze towards the target. Visual target is not necessarily needed in saccades. Nature of movement is ballistic. Main cortical area involved is frontal eye field. Cerebellum role is to accuracy of saccades. Clinical abnormality may produce slow hypermetric or hypometric saccades. Coming to smooth pursuit, the speed is slow. The function is to track the moving target. Visual target is necessarily needed. Nature of the movement is feedback controlled. Main cortical areas are MT, MST, and frontal eye fields. Role of cerebellum is to maintain the pursuit. Clinical abnormality is saccadic pursuits. Vestibular eye movements, retinal image stabilization during head motion. Vestibulo-ocular reflex is a vital physiological mechanism designed to maintain stable vision during head movement. It functions by ensuring that a visual field target remains fixed on the fovea even while the head is moving. Function is to allow for a clear vision during daily activities such as walking, running, climbing stairs. Without vestibulo-ocular reflex, in the absence of this reflex, image becomes blurred during head movement, reading while walking becomes difficult, visual acuity decreases, and individuals develop oscillopsia. Neural pathway and control. The vestibulo-ocular reflex relies on coordinated neural pathway and is fine-tuned by the cerebellum. The basic pathway is when the head rotates to the right horizontal semicircular canal gets excited, sending signals via vestibular nerve to the vestibular nuclei. Signal then travel through the medial longitudinal fasciculus to activate contralateral abducens and ipsilateral oculomotor nucleus, ultimately causing the eyes to move to the left. Cerebellar control. The cerebellum continuously calibrates the vestibulo-ocular reflex. The flocculus maintains the vestibulo-ocular reflex gain, while the nodulus and the uvula process the vestibular signals and control the velocity storage mechanism. Vestibulo-ocular reflex gain. This is the ratio of eye velocity to head velocity. A normal gain is approximately 1. Reduced gain is seen in vestibular disorders requiring corrective saccades to maintain the fixation. Suppression. Humans can voluntarily suppress the vestibulo-ocular reflex, example, when looking at the thumb while rotating with the thumb via the visual pursuit pathways involving the cerebellum and the visual cortex. Clinical assessment and disorders. Clinical evaluation is essential for diagnosing vestibulo-ocular reflex dysfunction, which can stem from peripheral and central lesions. Clinical assessment methods are Doll's eye maneuver. It's used to test the brainstem integrity and vestibular pathway. Head impulse test. Here we rapidly rotate the head. An abnormal result, that is presence of a catch-up saccade, suggests the peripheral vestibular lesion is present. Clinical disorders, bilateral vestibular failure, it's caused by factors like aminoglycoside toxicity, autoimmune vestibulopathy leading to oscillopsia. Unilateral vestibular lesions characterized by vertigo, nystagmus, and abnormal VOR towards the affected side. Cerebellar diseases leads to impaired VOR adaptation, defective suppression, and gaze instability. Brainstem lesions such as MLF or vestibular nuclear lesions causing impaired conjugate eye movements and abnormal VOR responses. Relationship between VOR, pursuit, and saccades. These systems work together to ensure stable vision in everyday life. Saccades help in shifting the gaze rapidly to the target, smooth pursuits following the moving targets. Vestibulo-ocular reflex stabilizes the gaze during head movement. Optokinetic systems stabilize the gaze during sustained visual motion. Optokinetic nystagmus. Optokinetic nystagmus consists of slow pursuit phase, tracking movements, and a fast corrective phase, saccadic movements, resetting the eyes. The function is to prevent the retinal image slip and supplements the vestibulo-ocular reflex, particularly during prolonged motion. Neural pathways. Subcortical pathway, primitive ones, are involving retina, optic tract, vestibular nuclei. It is present in the infants. Cortical pathway or the mature pathway involves retina, visual cortex, MT and MST areas, frontal eye fields, cerebellum, which is critical for conscious visual tracking. Cerebellar integration. The flocculus and paraflocculus maintain the pursuit movement and accuracy of optokinetic nystagmus. The nodulus and uvula integrate vestibular and visual motion information. Clinical assessment and significance. Clinical evaluation of these reflexes helps localize the brainstem, cerebellar, or cortical lesions. Examination method. Tools like optokinetic drum or tape are used to elicit optokinetic nystagmus. The examiner observes for a symmetric slow pursuit and a fast corrective saccades in both the directions. Diagnostic value. It helps in assessing brainstem, oculomotor, and visual pathways. It's useful for evaluating infant, uncooperative patient, and functional vision loss. Abnormalities. Parietal lobe lesions produces reduced optokinetic nystagmus towards the opposite side of lesion. Occipital lobe lesion, that is impaired motion perception and reduced optokinetic nystagmus. Cerebellar disorders, poor pursuit, reduced optokinetic nystagmus and saccadic pursuits. Brainstem lesion, asymmetric optokinetic nystagmus and abnormal gaze holding. Vestibulo-ocular reflex, it is driven by the vestibular nuclei. Primary context is rapid transient head movements. Optokinetic nystagmus, it is driven by visual stimuli. The primary context is prolonged sustained visual motion. Vergence eye movements. Vergence eye movements are disconjugate movements where the two eyes move in opposite direction to maintain the binocular alignment on the object at varying depths. These movements are essential for achieving binocular single vision, stereopsis, and depth perception. They are predominantly observed in frontal eye species, including humans. Convergence, the eyes move inward to focus on a near object. It is a component of near triad, which also includes accommodation, that is lens thickening, and meiosis, pupillary constriction in increased depth of field. Divergence, the eyes move outward for a distant fixation. It is less robust and less voluntarily controlled than convergence. Neural control. Vergence is governed by cortical areas like frontal eye field, parietal occipital visual association cortex, midbrain centers like supraoculomotor area, mesencephalic reticular formation, oculomotor complex, and the final pathway involving the medial rectus subnuclei of the third nerve and the medial rectus muscle. Clinical testing. Slow vergence. It is tested by having the patient to follow a target moving towards and away along the midline to assess the smooth depth tracking. Fast vergence, it is tested by having patients alternate gaze between the near and distant midline targets to assess the rapid vergence switching. Clinical disorders. Common symptoms. Patient with vergence dysfunction often present with binocular horizontal diplopia, eye strain, reading difficulty, blurred vision, headache, and loss of depth perception. A characteristic feature is that ocular movements remain fully normal despite the presence of diplopia. Convergence insufficiency, the most common convergence disorder, it involves an inability to maintain convergence during near viewing and is most often idiopathic, though it can be associated with aging or conditions like Parkinson's, MS, TBI, myasthenia. Convergence paralysis, a complete inability to converge localizes to the midbrain associated with conditions such as stroke, MS, tumors, hydrocephalus. Convergence spasms, characterized by intermittent excessive convergence, often due to functional or psychogenic causes or organic issues like midbrain lesions. Divergence insufficiency, failure of divergence during distant fixation, presenting with distance specific diplopia or esotropia. Here we can see images showing convergence paralysis and convergence spasm. The first image, convergence paralysis. The key feature are failure of convergence with the intact light and near reflex. It is often bilateral and look for the associated vertical gaze palsy and light near dissociation. Convergence spasm, the key points are involuntary convergence at a distance, inability to diverge, pupils often are miotic and poor light reaction, may be associated with altered sensorium fever, drug or toxin exposure. So the clinical tip is convergence paralysis is failure to converge, that is eyes diverge upon near reflex. Convergence spasm is inability to diverge, that is eyes stuck in convergence. Vergence disorders versus sixth nerve palsies. Ocular motility is fully normal in vergence disorders. Diplopia is for the near and distant specific. Localization is supranuclear. Whereas sixth nerve palsy, ocular motility is abduction weakness. Diplopia is worse towards the parietic side. Localization is either nuclear or infranuclear. Fixation. Nature of fixation, it is an active energy requiring process rather than simply the absence of movement. Neural mechanisms. Fixation neurons located in the rostral pole of superior colliculus serves to suppress the saccades. Fixation cells in the frontal eye field project to both superior colliculus and the brainstem reticular formation. The basal ganglia, specifically the substantia nigra pars reticulata, Maintains the tonic inhibition of the superior colliculus saccade neurons. Fixation failure. Failure of the system can manifest as square wave jerks, macrosaccadic oscillations, or opsoclonus. Skew deviation. Skew deviation is a supranuclear vertical strabismus characterized by the vertical eye misalignment. There is an imbalance in the prenuclear utriculo-ocular pathways that normally maintain the vertical alignment. The pathway involves utricle, vestibular nerve, vestibular nuclei, medial longitudinal fasciculus, interstitial nucleus of Cahill, and ocular motor nuclei. Symptoms include vertical diplopia, tilted images, dizziness, oscillopsia. Signs include hypertrophy, ocular torsion, head tilt, associated nystagmus. Ocular movements are usually full, distinguishing it from the peripheral nerve palsies. In skew deviation, the hypertrophic eye is intorted, whereas in fourth nerve palsy, it is extorted. The upright supine test is key bedside tool. Skew deviation shows more than 50% improvement in the supine position, while cranial nerve 4 palsy shows little or no change. Syndromic associations. Wallenberg syndrome often features skew deviation, torsion, and head tilt. Paranoid syndrome skew deviation combines vertical gaze palsy. Internuclear ophthalmoplegia skew deviation is associated with an MLF lesion. The horizontal gaze pathway. It is regulated by the PPRF and the abducens nucleus located in the pons. The function is the pathway ensures a conjugate horizontal eye movement by coordinated contraction of lateral rectus of one eye and the medial rectus of the other eye, while simultaneously inhibiting the antagonist muscle. The PPRF acts as a center of horizontal saccade gaze and projects to the ipsilateral abducens nucleus. The abducens nucleus contains two cell populations, one motor neuron that activate the ipsilateral lateral rectus and interneuron that decussate and ascend to the medial longitudinal fasciculus to contralateral medial rectus subnuclei. So the syndromes and involved structures and the clinical features. Horizontal gaze palsy. The structure involved is PPRF or abducens nucleus. Clinical feature is neither eye can look towards the side of lesion. PPRF lesions are mainly affect the saccades, while abducens nucleus lesions affect all form of horizontal gaze. Internuclear ophthalmoplegia. The lesion is at MLF. It leads to adduction failure in the one eye on the side of lesion. 1.5 syndrome. The lesion is at PPRF and adjacent MLF. The lesion is at PPRF or abducens nucleus with adjacent MLF. There will be ipsilateral horizontal gaze palsy 1 and INO when looking away from the lesion half. Only abduction of the contralateral eye is preserved. So it is 1.5 syndrome. 8.5 syndrome. 1.5 syndrome with 7th nerve fascicle involvement. This combines the feature of 1.5 syndrome with ipsilateral lower motor neuron facial palsy. Coming to 8.5 syndrome, 1.5 plus ipsilateral cranial nerve palsy, adjacent cranial nerve 7th fasciculus is involved. 9 syndrome, 8.5 plus hemiparesis or hemi-hyperanesthesia. The anatomical involvement is larger pontine lesion. 13.5 syndrome, 8.5 plus ipsilateral cranial nerve 5, that is trigeminal fascicle. 15.5 syndrome, 1.5 syndrome with bilateral cranial nerve 7 palsy, that is midline tegmental lesion. 16 syndrome, bilateral horizontal gaze palsies plus bilateral cranial nerve 7 palsy. Lesion is bilateral pontine. 16.5 syndrome, 8.5 plus ipsilateral cranial nerve 8th involvement, vestibulocochlear involvement. 20.5 syndrome, 1.5 plus bilateral 7 plus ipsilateral 5th nerve, that is extended midline involvement. 24.5, 8.5 plus bilateral cranial nerve 8 involvement, which is most extensive involvement. Clinical approach and observation. It is essential to observe the patient's baseline, that is visual acuity. Check this first, as impaired acuity can prevent fixation and confound subsequent results. Head position. Note any tilt or turn or chin repositioning. Old photographs can be helpful to establish the baseline. Lid and pupil position. Assess for asymmetry, ptosis, retraction and lag, as well as pupil size, anisocoria and proptosis. Spontaneous movement observed for nystagmus, intrusions and oscillations. Systematic functional testing, saccades, assessed for latency, velocity, amplitude, accuracy by having the patient alternate rapidly between the two targets. Pursuit, have the patient follow a slowly moving target. Cogwheeling movement indicates the impairment. Vergence, observe the eyes as they follow a target moving towards the nose and watch for the meiosis near response. Vestibulocular reflex, perform a head impulse test or assess the doll's eye reflex in uptended patients. Optokinetic nystagmus uses a stripe tape or a drum to test the pursuit, that is slow phase, and saccades, the fast phase of the optokinetic nystagmus. Supranuclear distinction. Supranuclear lesions typically disproportionately affect the saccades while vestibulocular reflex remains preserved. Nuclear infranuclear lesions, saccades, pursuits and VOR are all equally impaired. Test sequence. If a range limitation is overcome by oculocephalic, that is Doll's maneuver, or a caloric stimulation, the lesion is confirmed to be supranuclear. Progressive supranuclear palsy, it's a neurodegenerative tauopathy typically presenting after the age of 60. It is distinguished from IPD by early postural instability, a poor response to levodopa, axial rigidity, and characteristic supranuclear gaze abnormality. The clinical presentation and the ocular features. The hallmark ocular abnormality in PSP is supranuclear gaze palsy that primarily affects the vertical eye movement. The ocular manifestation arise from degeneration of the supranuclear gaze control network, including the frontal eye field, basal ganglia, superior colliculus, rostral interstitial nucleus of MLF, and interstitial nucleus of Cahal. Key ocular features of the PSP include saccade and pursuits. Patient often demonstrate a slowing of vertical saccades, particularly down-gaze saccades. The saccades may appear hypometric. Fixation and gaze. Frequent square wave jerks are observed, reflecting the defective fixation control. Disease progression. As the disease progresses, horizontal eye movement also becomes slow and restricted, eventually leading to severe ophthalmoplegia. In the end, complete external ophthalmoplegia is common, with the vestibulocular reflex being final class of movement to be affected. PSP eye sign timeline: early, slow vertical saccades occurring while range remains full and square wave jerks intrude on fixation. Mid, vertical gaze ranges become restricted and patient may exhibit curved oblique trajectory of attempting vertical gaze. Late, horizontal saccades become slow or hypometric and pursuit is lost in both the planes. In stage, complete external ophthalmoplegia develops. The eyelid abnormalities such as blepharospasm, lid retraction, and eye opening and closing apraxia may be present. Here we can see vertical saccades. Dorsal midbrain syndrome, also known as Parinod syndrome. Here there is supranuclear gaze paresis, while voluntary upgaze is impaired and vestibulocular reflex and Bell's phenomenon remain preserved. Convergence restriction nystagmus. This can be elicited on attempting upgaze, often by using the downward optokinetic nystagmus tape. Light near pupillary dissociation. The pupils are typically large and react to the near light but not to the light. Near sight but not to the light. Collier stuck lid sign. This presents as bilateral upper lid retraction. Here we can see Argyll-Robertson pupil, a rare pupillary abnormality where the pupils do not react to light but constrict normally during near focus, commonly linked with neurosyphilis. Second one is Collier's sign, lid retraction. Third one is
saccades upward. There they can be seen. The patient is being asked to observe a downward moving OKN target, eliciting upward saccades. This side view will allow you to see the retracting movements of the globes. saccades.
Causes and differential diagnosis. Tumors and structural issues like pineal gland tumors such as germinomas and pineocytomas and hydrocephalus or a shunt malfunction. Vascular and inflammatory causes like midbrain, thalamic stroke, hemorrhage, multiple sclerosis, neuromyelitis optica. Infections and metabolic causes like Whipple's disease, neurocysticercosis, syphilis, tuberculosis, Niemann-Pick type C, Wilson's disease, and B12 deficiencies. Take home pearls. Saccade slowness is the hallmark of supranuclear disease. If the vestibulocular reflex can overcome by a gaze limitation, the lesion is definitely supranuclear. When the cortex determines when and where the eye movements occur, and the brainstem determines how it occurs. Vertical gaze is controlled by the midbrain, whereas horizontal gaze is controlled by the pons.